The live stream is on its way up.
Good evening. I'm Dr. Kanisha Zimmerman from Duke University. On behalf of the ABC Science Collaborative, I'm pleased to welcome you to COVID-19 in the Classroom, the webinar series. Today we will have Dr. Sarah Armstrong talk to us about
The live stream is on its way up.
Kanisha, I think we're good. I think you can continue.
Okay. Good evening. I'm Kanisha Zimmerman. I'm an associate professor of pediatrics at Duke University. On behalf of the ABC Science Collaborative, I'm pleased to welcome you to the COVID-19 in the Classroom webinar series. We are very excited tonight to have Dr. Sarah Armstrong, who is a professor of pediatrics at Duke University, speak to us about planning to accommodate children, teachers, and staff with special needs. I will apologize just up front. I'm on clinical service tonight, so I may have to leave you in capable hands of Dr. Danny Benjamin, who is my partner. I'm also very excited to have multiple superintendents on the line with us tonight. Dr. Felder from Orange County, Dr. Cosby, Dr. Moore, and Dr. Mabenga. We're really excited that you've joined us tonight, as well as all of the superintendents who've joined us throughout the state. And we are very happy to have had questions submitted so that we can hopefully address those today. Danny, I will turn over to you to give some ground rules for the night.
Great. Thank you, Kanisha, and welcome again to all of our guests who are here either for the first time or multiple times. I'd like to start out by saying that typically what we do with this is we have questions that are provided by the school districts. These are from the teachers themselves, from within each district. We've had so many overlap in the questions, we thought it best to start lumping them together. And so rather than identifying the particular district from where these questions are coming from and having those superintendents ask those questions, we're going to go ahead and ask the questions of our colleagues directly. There'll be a few slides by our colleagues, our panelists, and then we'll go into the questions. And we would encourage everyone who is on the live stream to go ahead and put questions in, and we will take them as we can get to them. Typically, we have more questions than we have time during the hour. And if that's the case, we'll either address them in a future webinar, or we will put them in writing and up on the ABC website. So without any further delay, I believe Dr. Akinboyo, you're up. So Ibuken, if you could take the helm here, that would be great.
So actually, I'm just going to hand up to Dr. Armstrong to set the stage for what we're defining as special needs tonight.
Thank you.
Great. Well, thank you so much for having me tonight. I'm really happy to be there, to be here with you all. Tonight we're going to be focusing a little bit on special needs. And one of the first things that we think about is children with special needs. And so just to make sure we're all kind of on the same page when we're talking about what special needs means, we're thinking about for children things that include chronic conditions like asthma or diabetes or obesity. But also children with medical complexity, which I know many of the schools care for these children as well. Kids that may require medication administration during the day, may require assistance with feeding or toileting, or even breathing support during the day. And then the third category are children with mental health or developmental conditions, including anxiety, depression, ADHD, sensory or auditory processing disorders, or children who have autism spectrum disorders. So we'll go to the next slide. The other category that we wanted to think about, and really this came from the questions that were posed on the webinar, was thinking also about staff and teachers that may have special needs that would affect safe return to school. So this includes special needs that include chronic health conditions that may increase teachers and staff's risk for contracting an infection. And then there's a bunch of categories that kind of apply to everybody broadly: teachers, staff, students, families. Difficulty wearing a mask due to anxiety or sensory disorders. People who have somebody at home that they might be worried about because they have a medical condition or are vulnerable for some reason. And then increasingly, and we'll talk a little bit about this more, people that are of a racial or ethnic identity that we know has a known disparity for increased risk for getting coronavirus infection or having a more severe infection. So that's kind of just setting the stage for kind of what we're talking about tonight. If you could go to the next slide. Thank you. So in looking through the questions that were posed, we tried to lump them into 4 major categories of concerns that were expressed by the teachers and people who responded on the webinar, and then also submitted some concerns separately to the faculty here. One category are conditions that specifically might limit mask wearing ability, either for medical or other reasons, and that applies to both students and teachers. The second category are special services that we provide to the teachers provide to students that might require close or prolonged face-to-face contact with a student. The third category relates to transmission of coronavirus and body fluids, because we know that teachers and staff are often exposed to body fluids when they're caring for children with special needs. And then the fourth category are conditions that might place individuals or family members at home at high risk of more severe disease. So we'll cover each of these 4 categories then. Next slide.
Yeah, so one of the questions that we've been having quite a bit is, what special needs conditions hinder a child's ability or requirement to wear a mask? And if you all could address that first, please.
So I'll take this first question. And I think for some that have attended before, we have addressed masking. We'll have a few slides that review our conversations around masking. But the key question is here, what medical conditions could limit this child's ability? And the short answer is really very few medical conditions exist that would limit a child's ability to wear a mask. So currently, as we all know at this point, face coverings or masks, and pardon us, we will use it interchangeably through the slides, but we can address specific questions about masks as we go on. So face coverings are recommended for all children, including those with special needs, particularly when they're in a congregate setting. And all that means is a setting that's outside of the home where more than one child is gathered. Next slide, please. And why are we doing this? What have we learned from the early days of COVID-19? I think more than anything, we know that masking works. This is just a slide that goes through the x-axis reviews over time, what is happening in Duke University's health system as we're measuring the rates of infection. And sorry, the y-axis title is not included there, but it's really just the rate of infection that was occurring within our healthcare workers. So people that are frontline workers that are interacting with patients that may or may not have COVID throughout the pandemic. As you notice, the dates start from March and go all the way to about June. And that flat line, I see the red line flattening there, are healthcare worker infections from exposures to other healthcare workers. So as soon as we implemented masking, we know that in our communities, the rates of infections went up, and you can see that happens. What happens in the community would happen in any setting. But once we had masking of every healthcare worker within the hospital, we saw this flat lining of the rate. Next slide, please. So questions often abound about how to determine the best mask for you. So in the school setting and in most community settings, when we're referring to mask, we're really more referring to a face covering. It's not really a surgical mask. And a lot of evidence suggests that a poly blend, so just a slightly thicker cotton cloth face mask, should be sufficient, and the mask should not have an exhalation valve or vent. And we don't have a picture of it here. We've referred to it previously. And the point there is you really don't want something that opens up and allows whatever droplets we're trying to prevent just from spreading into your immediate environment. But surgical masks are slightly different. And I think the evidence around the use of surgical masks does suggest that it may be preferred for nursing areas. And this is consistent with what the CDC, state health department and local health departments have said. I think a lot of questions abound about what type of mask should be used for and with children that have special needs, or even other members of our community that have special needs. And we'll try to address that. Again, we always put a plug in for reaching out to your local public health department and the state if there's specific guidance that are confusing or are not as nuanced as you would prefer. And just as a reminder, with some of the more recent studies that have come out, the CDC is not recommending the use of gaiters, so the neck gaiters, or face shields alone. And I know this comes up quite often. People have used it successfully in other countries, but currently that's not the recommendation, particularly in the school setting. So the key exceptions to keep in mind, and I think this is still consistent with most of our state's guidance. There's some nuances about the age, but the key exceptions are that children less than 2 who may not be able to take off the mask or put it on by themselves are not required to wear a mask. And also just thinking through, the kids are not spewing as many droplets into our immediate environment. Any child or an adult that has any trouble breathing, such as having an acute asthma attack, not necessarily just a history of asthma, but actively in some kind of respiratory distress, or anyone that's unconscious or incapacitated in any way, should not be required to wear a mask. Next slide, please. I alluded to this earlier, but I wanted to mention, we oftentimes have people that may have missed some of our earlier webinars, but this was a CDC paper that shows the importance of masking. So basically in Rhode Island, they reviewed all of the cases that occurred in childcare programs. These were mostly daycares, but some of the data can be linked to what could happen in schools. And they had 20 child daycare programs that had at least one case of COVID-19, but didn't see any spread. But there are 2 key points here. So there were low rates of spread in childcare centers where masking occurred. And I have another study in a little bit that came from Utah that showed what could happen when masking doesn't occur. But you can see that as the line goes up, that just suggests that as we saw community spread in Rhode Island, there were increased number of cases in childcare centers. So we are all in this together. The more we do to reduce our community cases, the better it will be when and if children come together for learning, or in this case, special needs, children with special needs that may need to come back in person sooner than others. Next slide, please. So this was the other study I was talking about. So Rhode Island, pretty good job masking everywhere. There were some cases in communities, some cases in schools, but no spread within schools because of masking and some of the other procedures they took. This is just a summary of another CDC paper that came out recently that was looking at transmission dynamics, just looking at spread of COVID-19 in childcare facilities. And the table just breaks down what each facility was doing. Without going into the weeds too much, the concern that was raised here was that children may get COVID-19 in school and potentially spread it to their household members. But when you look at the patterns or the COVID-19 precautions that were present within the facilities that had an outbreak, so 3 different facilities, most of them required masking for staff. As you can see, facility C did not. Most did not, all of them did not require a mask for children older than 2 years of age. And these were facilities that catered to elementary school age children who, as we know, and we can talk about this some more, are able to wear a mask. Most were not enforcing the 6 feet of distance when you can. And unfortunately, in all of these clusters, in all of these cases, in these facilities, the initial person that brought in COVID-19 happened to be a staff member who worked after an exposure in their household to someone that was ill or being sick themselves. So again, we're still fully supportive of all of the measures, temperature checking, symptom screening, but those by themselves may not be enough. And masking certainly works for kids, particularly those older than 2, and we should all continue all of the precautions that we're taking to prevent COVID-19. Next slide, please. And finally, we can be a little more specific about how to help children with disabilities become more comfortable with masks. It is a new habit. This is not something that kids have necessarily done before. And I think we as adults can play a huge part in normalizing the use of masks. So for example, if you're a parent in this context, you can look in the mirror with face masks and talk about it. Ensure that they could maybe help you make a mask and put a face covering or a mask on a favorite stuffed animal. Decorating it so it's a little bit more personal, a little bit more fun. Some people have tried to use book characters. Some of them have used animated characters, and there are lots of great examples on the market right now. And of course, asking parents, teachers, staff members to have the child practice rather than forcing, just practice and increase the amount of time a child has the mask on even prior to going into the congregate setting or school. Next slide, please.
So before we go on to question 2, I want to pass on some experience from some of our other superintendents and other school districts that are open right now. And as I outline the experience from these school districts and these superintendents, Ibekin and Sarah, I'd like for you to maybe pass on your experience from the hospital setting and the clinical setting, if you would, to outline for us if it's dramatically different or similar. So in the setting, and we've had a number of questions come into the chat, what happens in some of our adaptive curriculum or special needs students where they're not able to wear masks? How do we protect ourselves? So I just want to give folks some numbers from around the state, because as some of you all know, we're working with approximately 50 school districts and over 2/3 of all the school children in North Carolina at the moment. And the districts that are open, that are working with us, have reported a masking compliance in the mainstream student population. So even students with a 504 or an IEP in place, they're in the mainstream student population, a masking compliance of greater than 99% across their school districts. Most of the superintendents we've spoken to with tens of thousands of students can name the students or the families by name for whom there's lack of compliance. It is such a rare event in those school districts. That's number one. Number two is in the adaptive curriculum, and I was pleasantly surprised to hear this, but in the adaptive curriculum, most of the superintendents are reporting, all of them thus far are reporting that most of their children in the adaptive curriculum are wearing masks. And most of the superintendents are reporting to us 75 to 80% of their students in the adaptive curriculum are wearing masks. Davie County reported to us at 75%. Stanley County, for example, reported to us at 80%. And then a considerable number of those children in the adaptive curriculum who simply are not able to wear a mask. And there are some of those children. Some of those children are able to wear a face shield, or considerably others are able to be cared for from enough of a distance to protect teachers who are wearing masks. And then the final point is that none of those school districts report a single case of secondary transmission, that is transmission from child to staff member, in the adaptive curriculum since they've been open. So I'd like to ask Dr. Armstrong first in the outpatient clinical setting. I know you see children in the outpatient clinic, and then Dr. Akinboyo for the inpatient setting. Can you, what's your experience in caring for patients, the frequency with which they can wear masks, and how we handle that when they can't?
Sure. Thanks so much for asking. Yeah, we've learned a lot over these past few months, I think, about how to adapt to this situation, and hopefully some of those lessons we've learned can help inform school settings. As Dr. Akinboyo has mentioned, children under 2 really have a hard time wearing a mask, keeping it on. And so when we see patients in clinical settings where we're going to be face to face for a longer period of time with them, we have our surgical mask that we wear in the healthcare setting. And in addition to that, we'll wear a face shield for eye protection in addition to that. So we've kind of started doing that routinely with children under 2. And I have to say, I really do echo the comments from the other district superintendents in terms of compliance with masking among my patients' children with disabilities. Their parents have taken multiple approaches to help them be more comfortable with it. But I have children with both physical, developmental disabilities, behavioral issues and concerns that have tolerated the face mask, at least for the duration of a clinic visit, which I recognize is shorter than a school day, without much difficulty. So again, we take extra precautions ourselves when we think we might be at risk or the child might not be able to mask appropriately. But the disabilities aspect has not proven a significant concern in our clinics.
Great. Evikan?
I would agree, and we have a whole webinar that was dedicated to this. I see patients in clinic as well. I heard a different definition of disabilities this past week, sort of differently abled, and I like that term a lot, because I think with some coaching, particularly with children that might not be at the same developmental level as others in their age, they've been able to consistently comply with a mask. Of course, it doesn't last through the entire visit, but they can always go back to it. And brief periods are likely okay. I think we have a few slides that talk about exposure period, and we can address it some more if there are specific questions around masking. But in my experience in the hospital and in clinics, even our children that are differently able are able to wear a mask.
Great, thank you. And then this is a follow-up question, and I'm smiling a little bit because I had the exact same question that follows for the superintendents, and that is, are the children wearing a mask properly and wearing them all day, or are they just showing up with the masks on? Which I think is a fabulous question, because of course the mask does not do any good if I just show up in the parking lot with it on and then don't wear it for the rest of the school day. And the answer that I received from this, our partnering superintendents, was resoundingly that they are able to have them on all day, that they are, that they personally walk into their schools and see an extremely high rate of compliance, that they occasionally will have to tell some of the children in the mainstream curriculum to pull the mask over the nose. I would say, relative to what I see adults doing as I walk through town here, the children in these districts that are going to school are doing an outstanding job. I would call it leading by example, if you will. We'll get back to some more questions on from teachers from who are on tonight, but I wanted to go ahead and go to the next slide, which I think is also going to get started off by Dr. Armstrong. Sarah, is this your question around which special needs are associated with increased risk?
Mm-hmm.
Great.
Yeah, I'm happy to take this one. So this first slide is not meant to be alarming, and I think this is information that has been presented to people previously, and I think folks are kind of aware of this. Or these are the health conditions in adults that are associated with increased risk for infection. And so what we do with this information, I think, is an ongoing conversation. But in particular for adults, asthma, which Dr. Akinboyo reminded me is not what we're seeing in children, but also high blood pressure, obesity, which is true also in children, diabetes, kidney disease, and then combinations of these conditions do place people at higher risk. So these are folks that want to think about taking additional precautions just to improve their risk. And also, if you have somebody at home with any of these conditions, just to be aware of what we're seeing in terms of the evidence for increased risk. Next slide. Okay, now this is an issue that is, frankly quite upsetting, particularly in the context of the national conversation right now around race and ethnicity. But, certainly health disparities for people of color are not new. But COVID-19 has really shined a bright light on those disparities. And unfortunately, we are seeing in children, similar to as in adults, really different rates of both infection and illness from COVID-19 that are disproportionately borne by African American and Hispanic children. So again, what we do with this information, I think, is for further discussion. I think we need to be aware of it. I think we need to be actively trying to understand and root out the causes of it. But I did want this group to just be aware of that particular disparity. And then the next slide. So this shows a little bit of, again, we're getting a little bit away from special needs risk related to the child. These are sort of more in the category of special conditions or considerations for risk, but the number of people in the household seems to matter. And so there was a study looking at the number of people in households, and it found that the more people in the household, the more likely people are to have an infection. Interestingly, some of this may explain some of the race and ethnicity variations, although certainly not all of it. But it is seen that there are greater household members, particularly among our Hispanic community, and that does explain some of this difference in increased rates, certainly not all of it. But that is just another consideration to have when you have children or families that have a lot of people living under one roof and are exposed to each other. Next slide. And this is another, frankly, quite upsetting disparity that we're seeing that just, again, we should all be aware of. This is a study that took place just outside of Washington, D.C., or inside, and then the surrounding areas around Washington, D.C. So I'll walk you through it a little bit. On the left side, what you're seeing is the light colors are the the higher income neighborhoods, and the darker colors are the lower income neighborhoods. And what you're seeing is the white dots on the left show where testing is taking place. So you can see that even the testing facilities are really appropriated more to the higher income neighborhoods so that those people have better access to frequent testing and presumably then earlier treatment than people in the lower income neighborhoods. So this is concerning for our children who are living in those darker green areas. The one on the right shows the positive rate, and what you can see is those are pretty scattered. So even the children who are not getting access to testing, of course, are positive. And it was interesting, the authors of this study even said that, for the sites that they were recruiting from for this study, the ones that went to the African-American neighborhoods were set up last, as compared with the sites that were set up in the more affluent and predominantly majority neighborhoods. So I think we have a lot of work to do here, but we just wanted to make sure everyone was aware that this is going on. Next slide.
Dr. Armstrong, as you're talking about that, I just wanted to clarify a couple of things. So presented a lot of data about African-American children and Hispanic children being at higher risk, not only for COVID-19 infection, but also for more severe disease. Is it correct to say, or are you saying through these other slides that there are probably additional reasons for that that are not necessarily related to race or ethnicity, but perhaps related to other things that are related to race and ethnicity? Could you just clarify that for me?
Yeah, thank you for asking that. I mean, I think, you know, unfortunately, when we have documentation of racial and ethnic disparities in any kind of disease process, there's some erroneous tendencies that tend to rush in to fill the gap with explanations. People, for example, might say that there's biology to blame. People might say that individuals are misbehaving in certain groups, and you know that certain groups of people maybe don't wear masks as often as they should. So there's sort of a tendency to blame the affected group. And so we have to be careful of that and really look for the reasons that we think are probably more likely to be true. So for example, associations between income and certain racial and ethnic groups could be part of the explanation. Associations between frontline workers and certain racial and ethnic groups. And we know our, you know, our Hispanic families make up a large portion of the farm workers in this state, and they have kept our economy going and put food on the table by being exposed every day. And that could be one of the reasons that they've been more infected. So we're still learning what those true reasons are, but we have to be careful not to you know, assume that we understand those associations till we know for sure.
Thank you. So another question. So how can we safely deliver services that require close or prolonged contact? Dr. Gamboya, would you like to take that one?
I certainly can. For some reason, I couldn't unmute as quickly. So I think we can address this a few different ways, and I may go through a few slides just kind of talking about this. Oh, and then just a quick note, we did get the comment about the differently abled, and so my apologies. This was a definition that was provided to me by someone that identifies as disabled, but we are all learning and we will continue to learn. So for the question regarding delivering services, particularly when someone has a special need and you have to be in close contact, the recommendation has been to consider adding a face shield in addition to a face mask, if it's possible. We can talk some more about the evidence around this. And I think if you have technological assistance, that may also be the goal here. I think we're talking about this both virtually, but also in person, and trying to accommodate for everything. And it might be slightly different, depends on the setup. I also think if a child just has no ability at all to tolerate the mask, particularly for those that either have sensory anxiety or some autism spectrum disorders, we've discussed and we're trying to ensure this is compliant. This is in accordance with the North Carolina Health Department's guidance, but enhanced PPE may be used in that context. And this is slightly different from the cloth mask. It may require a surgical mask and maybe a mask and face shield, but I think the science here is evolving. I think the conversation should be started. We would love to talk with the superintendent some more and all of the people that are decision makers around this to see if this may be an option. But if the child can be masked, that should still be the preference, and then having the teachers and staff wear masks as well. Next slide, please.
So is COVID-19 transmitted in body fluids that I might be exposed to? Dr. Benjamin, would you like to answer that question?
I'm happy to answer that. And the answer is almost certainly no. The longer answer is we have not seen reports of that transmission around body fluids. I want to separate out body fluids such as waste, feces, urine, where the answer is almost certainly no, versus from saliva or from spitting, where it is this is a respiratory virus. Because it's a respiratory virus, this is where the transmission occurs, is from exhalation of droplets and particles. So aside from the respiratory type body fluids, the answer is no. It's possible. Anything's possible in medicine, but it has not been documented.
Thank you very much. I just wanted to take maybe a couple of questions from the chat. There are many that are coming in. Dr. Akinboyu, children with IDD are 160 times more likely to die from COVID than their non-disabled peers. Why is this not being discussed, or can you provide some explanation for what's happening here?
To make sure we're on the same page, should we spell out what IDD stands for?
Yeah, I think Dr. Akinboyu, the question, it's the understanding of the person asking the question that children with intellectual and other developmental disabilities are at a much higher risk of death. We've had two separate questions about that. Okay. One question quoted a number of a 160-fold increased risk and probability of death from COVID in children with disabilities. If you could, I think that this is based on a case control study, and I'm not sure of how thorough the peer review was of that, but I think what the person asking the question was that there were 450 patients with IDD and 30,000 patients without, and the risk of death in the patients with IDD was 1.6% compared to those without at 0.1%.
Got it. So I have not read that paper specifically, but that the comment is correct in that we have seen a slightly increased risk of mortality. So keeping in mind the number of children, unfortunately, any death here is serious, but the number of children and the proportion that we've attributed to COVID-related mortality is still pretty low. But amongst those kids, it does seem that there seems to be a higher risk amongst children that have some level of intellectual disability. And I think at least one of the papers I saw alluded to things like Down syndrome. And I think what we're trying to parse out is which one comes first, such that is it related to some of the additional things similar to what we were saying about disparities? So linking poverty and race in this context, is it related more to diabetes, obesity, and either heart or lung conditions as compared to the developmental disability? But that also raises the next point, which is everything we're discussing has to be in the context of what has gone on so far. So there are some children, particularly those with special needs, that we do need to take additional precautions, both in how they are learning and being educated, but also in how we're applying our COVID-related precautions. And that's why we mentioned it may require staff members to have enhanced PPE, slightly different from the classroom settings where children without obvious disabilities are being educated.
Okay, and I will say that, so in summary, it seems like, again, I'm not a mind reader of the person who's asking the question, but it seems like two things. One is that there has been a study published with a 10 to 16-fold higher risk for mortality with IDD. And that although that may well be an overestimate, because sometimes things are an overestimate in the peer review literature, that has been replicated, Dr. Akinboyo, in your reading of the literature, that has been replicated in the sense that it appears that children with disabilities do have a somewhat higher risk of mortality. Is that correct? Am I understanding you correctly?
So I'll say they have a slightly increased risk of severe infection. So all that means is if you already have a comorbidity, if you already have some chronic condition that we're trying to manage medically, and then you get another hit, there's a higher chance that you end up in the hospital. If you end up in the hospital, unfortunately, there may be a higher chance that your infection is more serious and could ultimately lead to an increased risk of death. But I don't think in the entirety of the data suggests that just a disability is the link here.
Okay, great. So maybe a little bit higher risk, but the numbers of tenfold or more higher risk is likely to be an overestimate. What we're talking about is a slightly higher risk of hospitalization for children with IDD. Is that correct?
Possibly.
Okay, great.
Mhm.
Thank you.
Mhm.
Dr. Zimmerman, I think you've got one from the chat. Is that correct?
There are many from the chat. I will try to work through them. Let's see here. There was a question specifically about see-through masks and potentially around the benefit or lack of need for any of those. Dr. Armstrong or Dr. Akinboyo?
Yeah, can we go to the next slide, please? And we may not get through all the slides, but just as a reminder, we will certainly have these available, and they contain a number of resources that can address some of these questions. But yes, I think the question was related to the use of clear masks, particularly for both kids at the developmental stage where they may need to read lips, or those that require additional help. And I think the Claire mask, there's no brand here. I'm not trying to promote any brands, but it may be an option. Again, face shields by themselves may not be as protective, or actually will not be as protective, and is not really recommended currently, but maybe options in some settings. And then the question around eye protections, particularly if you're interacting with a child that might be spitting, or you may have exposures to bodily fluids, and we had a long list. I think eye protection will be useful. Some people are already wearing this while flying due to the increased risk, and there are many on the market that are fairly affordable, and it may be something to consider.
Thank you very much. Dr. Benjamin, I'm not sure you're there, but there are a couple of questions that I think are related to what some of the superintendents have been saying. One, I think, is whether or not there were penalties related to non-enforcement of masks within the other districts. And I think there's also a question about people showing up with masks and wearing them all day or just part of the time. Can you just speak maybe a little bit more to what's happening? How do people know also that people are masking 99% of the time? Are the superintendents there all the time, or how are they marking these things?
Yeah, so let's see, let's take those one by one. I don't think that we're in a situation where we're in a police state in these schools, right? We're not having filming and sirens go off when people are not wearing masks. From what I've hearing secondhand from the superintendents is that the community in which they live have really come together in a positive way and have committed to wearing the masks, to wearing them consistently, and to wearing them at a very, very high rate. Number one. Number two is that whether or not the compliance is 99% or 98%, the evidence of their success is in the 0 transmission rate within schools, that is the 0 secondary cases that they're experiencing in these school districts. So that with a very high compliance rate of masking in a hybrid model of education and a culture of hand washing, school districts, dozens of school districts in North Carolina are open and opening successfully and opening safely for the past month.
Thank you. So 2 additional questions. Dr. Akinboye, could you maybe speak to how we might be able to safely give mask breaks?
Yes, so this is regarding teachers because we spoke about students in a prior webinar. Could we move to the slide around where teachers can take breaks, just so I can walk through those real quick? So we can start with this one and then go to the next slide. So we can start with the slide prior. Thank you, Helen. So I think some questions around breaks and also around what teachers can do, teachers and staff members really, to protect themselves involved. Do you need to do anything special? Do you need to wear clothing that's different? And I think the short answer is probably not, but being careful is certainly a good idea. And if you are working with children with special needs and have close in-person interaction, it may not be a bad idea to have dedicated work clothing. But washing your hands and masking is really the goal. Next slide, please. And of course, when is it okay to remove your mask? We wear masks at work all day, every day, and sometimes that can get tiring, particularly on the ears if you're wearing the ear loops or the face covering, even if it's made of soft clothing. So if just remembering the key ways this virus can spread will help with answering this question. So if alone in a closed office, in a closed classroom for very brief periods, it's likely fine. But while indoors, I think even with the use of plexiglass, and I don't think plexiglass has been a tool that most schools are using, but even with that, it's a physical barrier, but it doesn't really limit the amount of droplets we're releasing. So I would still recommend wearing a mask in that context. And then as I mentioned earlier, some people consider the use of the Clear mask, which is still a face covering, but has a plastic covering and it's well sealed and fits the face really well. So those are some options. I think outdoors, short periods, if you're alone indoors, maybe options for when it's okay to remove a mask.
Thank you, Dr. Akinboye. Dr. Armstrong, there are multiple questions that are referring to circumstances where masks might be pulled off or face shields. Can you just speak to how we might protect ourselves in those situations?
Yeah, and look, there's no super easy answers, as with many things with kids with with these disabilities that prevent them from feeling comfortable with that, and they may pull them down. They may reach and pull their friend's mask down. All of those things, we're dealing with, a group of kids where that could very well happen. I think the way to think about that, and I just putting on sort of my behavioralist hat, and most of these strategies, honestly, I learned from my children's teachers in the Chapel Hill Carborough School District, which is to say those same strategies that we use to enforce behaviors for all of the other things will hopefully be something that can at least help in this situation too. So can kids receive rewards for keeping their masks on properly? Can we make a game out of keeping masks on properly? One of the rewards could be, as Dr. Akinboye said, mask breaks that are done outdoors safely and distanced as a reward for good mask wearing behavior. So I think, the teachers themselves probably have the best ideas for how to handle those behavioral considerations, but that might be sort of applying those strategies to the mask wearing is probably the best bet.
Great, thank you. There is a question also in the chat about inability to properly wash hands and how we might be able to help with sanitizing in that particular situation. Dr. Akinboye, do you have some thoughts?
Yes, and I'll pick up on what Dr. Armstrong said, which is we're learning from you all about practical solutions within the schools. We can discuss about the data. And I think the data suggests that if you can get a wipe or soap and water and safely do that, that may be the best bet. And the goal is to limit the viral particles or just what is contaminating the child's hand, particularly if they're touching things that are going to be shared. But for the most part, a safe way would be just wipe down and let it dry as an option if they cannot rub their hands together and wash with soap and water or use the hand sanitizer safely.
And Dr. Ekamboa, just to follow up on that, I do hand hygiene on myself. I wash my hands, then I assist the student or the patient. And then even if that just means letting it air dry, and then I do hand hygiene on myself, right?
Absolutely, yes. So we've not emphasized this as much. Thank you for bringing that up. But all of these interactions, so helping a child with a face mask or not, if they do not have a face mask on or they pull it off because we know how children may get tired of it. Washing your hands before interaction and after interaction, before school, after classes, just kind of building that habit into every interaction will be key in reducing spread.
Great, thank you so much. Another question that's coming out of the chat is related to clothing. So coming home and having maybe had some interactions. One, should there be special clothing that should be worn at school? And then two, when you get home, what should be done? Should this be washed on hot water and put on high heat in the dryer? So how should we handle this?
So I can address that. I think we've talked about this somewhat in some of our prior ones, but we can also have the FAQs dedicated to addressing this. So what do we do in the hospital where people are taking care of patients that already have COVID-19? For the most part, a lot of people may wear scrubs, which is a dedicated work uniform. Not everyone does this, particularly those that may come in and out of a room. Most often you can wash your whatever clothing you wear all day in a washer dryer by hand, but using warm water and soap should be fine. It can be washed with your regular load. This virus does not necessarily spread by clothing or through clothing, so that is not the highest risk of spread. And if you're washing your hands as you're moving from one setting to the other, I think that will be the priority for reducing spread as compared to what you're wearing. That being said, I think if you have dedicated work clothes, you take it off as soon as you get home, wash your hands as soon as you get home, and just wash it with your regular load. That would be what I would advise.
Let's see here. There are some questions about number of students in a classroom, particularly young pre-K students. Should there be a limitation to the number?
Sure, we can address some of these. I think in general, of course, less people in a room that you can at least give some space. We've said 6 feet in the United States. A lot of countries have done that 3 to 6 feet, particularly if they're masks. If they're not wearing a face covering or mask and indoors, certainly spacing them out much further is a good idea. And all of these things are on a spectrum. The more things you do together, the more COVID precautions you take, the less likely you will see spread. And so, of course, spacing kids out, having a few enough kids in a classroom that you can space them out would be the goal.
All right, I'm going to give you 2 more questions. So, and they're related to, there was a question early on, I think, about the suddenly we are seeing more infections in kids. Can you maybe talk to why that might be? And then there's also a question specifically about contrasting Georgia with Rhode Island and Utah, and why are they different?
Yeah, so I can answer the latter one first. Again, I'll put a plug into other conversations we had around this. We have webinar links, and we discussed the Georgia study in a prior conversation, I believe. And what we saw there, so in the camp setting, in some of the school settings, were inconsistent mask compliance and distancing compliance. And I think also I think the key point here was higher community rates. So if you have high community prevalence, you will see higher rates of infections in any setting you put kids into. So they kind of go hand in hand, unfortunately. But yes, there are many states that have pushed out data, and we have reviewed, I think, a number of them that are pertinent to this discussion. Do we have time for the other question? I think so. Okay,
Yes,
and
so
that was, can you remind me what it was regarding?
So increase in number of infections in kids that's been reported recently.
Yes, so just 2 quick comments there. We are testing more kids. It took us a while so kids were not in person. And so for the most part, kids may have been exposed, but they were home and we were not able to get them tested as frequently as we were testing adults. We're testing more kids, so we're seeing more infections. And also we're testing asymptomatic people. We're testing kids without symptoms, which I think is important. We've seen a different pattern of infection spread in kids, and some of them may have mild to no symptoms. And North Carolina has shifted to have a standing order that accommodates for this. And so that's why we're seeing an increased number. But as a whole, the number of cases, thankfully, have started to go down a little bit more over the last couple of weeks.
and just to follow up on that, what we're seeing in school districts that are opening with a detailed plan on wearing masks, washing hands, and maintaining distancing in a hybrid model. We're seeing those school districts and those universities have success in opening up. And what we're seeing in school districts that are not doing those things, we're seeing a great deal of failure, be it in a K through 12 public school setting, an overnight camp, a day camp, an after school program. And so it's really a question of having the detailed plan outlined that makes it possible for success, leadership to execute on the plan, and commitment by all folks on the property to make this a success, whether one's in a camp, a school, a hospital, an office environment, whatever environment one is in. We've simply got to work together. And if we're going to be successful, and it's clear that not all things should be open at all times, but the ways that folks have opened and stayed open is through adherence to the principles around masking and distancing, et cetera. This is a topic that may require another webinar, given the time of night that it is. We've certainly had more questions than we've been able to address. And as usual, Dr. Zimmerman, you're going to have the last word here at 7 p.m.
So we really appreciate their engagement tonight, and there will this recording will be available on the website. We will provide that information to you through your schools and your PIOs. We also recognize that there were lots of questions in the chat that we didn't get to, and so we'll be trying to address those in future webinars or in the FAQ document. And also, just as a reminder that we all want to be safe and we all want to find the best way and the best pathway forward. I think that's the #1 priority, best pathway for teachers and kids and everyone. And so that's going to just require some work. And that's okay. But I hope that you guys all have a great night, and we will see you next week. Thank you.
Thank you.